Thank you very much. And next up is Professor Domenico Corrado from Padua, who really doesn't need much of an introduction, but I would like to just say a few words about him. He has contributed extensively to sports cardiology, and he was actually the lead author for the 2010 ESC recommendations for ECG interpretation in athletes, which have been used so widely. He has contributed extensively to the electrophysiology, the structural knowledge that we have of ARVC, and now has focused a lot on ALVC. But what he's going to talk to us today about is ventricular extrasystoles. We know that these are common and can often be benign, but sometimes they can be a marker of very serious cardiac diseases. And he's going to give us a lecture on how to interpret them in the most simplistic terms. Over to you, Domenico.
Thank you, Sanjay and Michael, for inviting me to this conference, CROI conference. To discuss with you about the ventricular ectopy in the athletes, interpretation and risk stratification. So sudden cardiac death in the athletes is usually the result of an acute electrical ventricular instability that is associated with the underlying cardiovascular disorder, that according to this distribution of sudden cardiac death in young people in the Veneto region of Italy, first include cardiomyopathies, followed by coronary atherosclerosis, premature coronary atherosclerosis in this age group, and valve disease, non-atherosclerotic coronary artery disease, myocarditis, and so on. You can see here a representative example of major substrate of sudden cardiac death in athletes. Top left, you can see athletes dying suddenly due to hypertrophic cardiomyopathy. Top right, an athlete who dies suddenly due to arrhythmogenic right ventricular cardiomyopathies. Both are genetic cardiomyopathies predisposing to the risk of sudden cardiac death. Bottom left, an example of an athlete dying suddenly due to premature coronary atherosclerosis with occlusive thrombosis. And bottom right, an example of congenital abnormal origin of the left coronary artery from the right coronary sinus, a congenital coronary anomaly. All these conditions predispose to ventricular fibrillation, is the arrhythmia you can see bottom. That is the mechanism of sudden cardiac death. It is common to all these conditions. So this explains why to identify ventricular arrhythmias on the athlete ECG for cardiologists or for medical physician is an alarming sign of cardiovascular risk that increases with the increasing complexity of the recorded arrhythmias that may vary from isolated primary ventricular beats, repetitive non-sustained ventricular tachycardia, sustained VT, polymorphic VT, and ventricular fibrillation that is usually the cause of cardiac arrest. So we recently published a paper addressing the prevalence, determinants, and underlying subset of ventricular arrhythmias in young competitive athletes. We used the 12 leads 24 hours ambulatory electrocardiogram recording in order to record the number and, most importantly, the morphology of arrhythmias in athletes versus controls. And you can see here that more than 1 per hour isolated premature ventricular beat, or 1 or more couplet, triplet, or non-sustained ventricular tachycardia was recorded in a minority of athletes, less than 10%. And this prevalence of ventricular arrhythmias in the athletes didn't differ from that recorded in controls, you can see that we found arrhythmias in 11.3% of controls. There was another important result, no association between the presence of ventricular arrhythmias in athletes and the degree of training, the years of sport activity, and the type of sport activity, endurance versus non-endurance sport activity. So ventricular arrhythmias were not associated with sport activity. Most importantly, to detect a ventricular arrhythmia in an athlete should prompt evaluation, clinical evaluation of an underlying cardiac disease that is most important risk factor. So you can see that in our study, all the athletes with ventricular arrhythmias underwent echocardiography that was always negative, and a sizable proportion of them underwent cardiac magnetic resonance. Of interest, the morphology of ventricular arrhythmias associated with the pathologic cardiac magnetic resonance findings was a right bundle branch block morphology rather than a left bundle branch block morphology. So, according to the recommendation for competitive sport participation in athletes with ventricular tachyarrhythmia, you can see here that the eligibility to competitive sport activity can be fulfilled in the absence of cardiac disease of arrhythmogenic condition. But how much should be deep the cardiac evaluation in order to exclude the cardiac disease of arrhythmogenic condition? Because the clinical workup can include the basal electrocardiogram, the stress testing, the Holter monitoring, echocardiogram, but also more sophisticated tests such as cardiac magnetic resonance or invasive tests such as angiography or endomyocardial biopsy. So when should we stop in order to evaluate the presence of an underlying cardiovascular disorder or to unmask potentially silent myocardial cardiovascular substrates of the arrhythmia? So we usually propose guidelines for evaluation of premature ventricular beats in the athletes in terms of diagnosis and management, and also propose the diagnostic algorithm. And you can see here that we classify premature ventricular beats in common and uncommon based on the prevalence. And this distinction, this classification was essentially based on a series of parameters that included the complexity of the arrhythmia, the response to exercise, the morphology, and the association with the clinical findings. You can see here that common premature ventricular beats were characterized by the lack of association with the clinical findings, such as symptoms, other ECG abnormalities of imaging abnormalities, was characterized by the pattern of isolated monomorphic ventricular ectopies, by the decrease or suppression of ventricular arrhythmias with the exercise, and most importantly, to a specific morphology. Morphology of ventricular arrhythmias is a key marker for recertification because some morphologies denote a so-called idiopathic ventricular arrhythmia. That means an ventricular arrhythmia that is not associated with the underlying cardiovascular disease and is characterized by a benign outcome. These morphologies, these patterns of ventricular arrhythmias, idiopathic, so benign, are those characterized by are the so-called outflow type ventricular arrhythmias and fascicular ventricular arrhythmias. I will show you some example of the most common idiopathic preventricular beats that is characterized by a left bundle branch block morphology and inferior axis, the so-called right ventricular outflow tract idiopathic premature ventricular beats. These are the fairly the most common premature ventricular beats in young people and athletes, and are characteristically benign. So the modern perspective is that it's better to define this kind of arrhythmia as outflow type ventricular arrhythmia because they can also originate from the left ventricular outflow tract other than the right ventricular outflow tract. And the morphology of the ectopic QRS in V1 lead can help you to identify the site of origin. You can see here that from the right ventricular flow tract, usually the morphology is a QS in V1, and for example, if the premotor ventricular bits originate from the left outflow tract of the mitral valve annulus in V1, you record a predominantly positive QRS. So the other pattern of idiopathic ventricular arrhythmias is characterized by a right bundle branch block morphology with superior axis. Most importantly, this idiopathic morphology is characterized by a narrow QRS, less than 0.13, 0.12 seconds. And this kind of arrhythmias originate very close to the specialized conduction tissue, usually from the inferolateral part of the inferapical part of the left ventricle, close to the anterior left fascicle. And you can see this explains why the QRS is narrow, because it originates very close to the specialized conduction tissue. So by contrary, uncommon premotor ventricular beats are characterized by different findings. They may be associated with clinical findings such as symptoms, other ECG abnormalities, mostly T-wave inversion on the electrocardiogram, or imaging abnormalities, for example, myocardial fibrosis or cardiac magnetic resonance. You can see here that these uncommon premotor ventricular beats, that means that they occur in less than 10% of young people and athletes. They are more often complex. That means they can be repetitive or polymorphic. They can persist or increase during exercise. And most importantly, they exhibit a particular morphology of the ectopic QRS. You can see an example of an uncommon morphology that is characterized by a left bundle branch block morphology pattern with the superior axis. In this particular case, the premotor ventricular beat is associated with repolarization abnormalities such as T-wave inversion from V1 to V4, and actually these premotor ventricular beats is a marker of an underlying arrhythmogenic right ventricular cardiomyopathy, as you can see here. The association with the right ventricular dilatation dysfunction, a large electroanatomic scar on voltage mapping, and a positive endomyocardial biopsy for fibrofatty myocardial replacement. Another morphology is a right bundle branch block and the superior axis, but in this particular case associated with a wide QRS. That means that the premotor ventricular beats originates from the remote myocardium, not from the specialized conduction tissue. And you can see here that these particular premotor ventricular beats may be complex, may increase in complexity during exercise, and can be a marker of non-ischemic myocardial fibrosis, either post-myocarditis or cardiomyopathic. The third example is the morphology of uncommon morphology of premotor ventricular beats is right bundle branch block, an inferior or intermediate axis, and large wide QRS that can originate in the context of an arrhythmic mitral valve prolapse. That means ventricular arrhythmias through floppy mitral valve and the presence of myocardial fibrosis in the myocardium, the posterobasal myocardium, the myocardium close to the attachment of the papillary muscle. So the poll one is the following. 23-year-old rugby player, how would you classify the premotor ventricular beat morphology in this particular case? A, common, B, uncommon. Please vote.
Okay, so this is actually a bit easier because you had some teaching on it already by Professor Corrado. So look at this particular ectopy and decide whether you will put it in the common or the uncommon group. So people are voting. We've got very few votes for now. I don't know if that means people are thinking. Now we're picking up a bit. I'll have a careful look at the ventricular ectopy. See obviously whether you block. Look at the QRS duration. Look at the axis. And then you'll be able to make a decision. So we've got about 30 votes. And it seems that the majority, 2/3, have gone for common, Professor Corrado, and 1/3 has gone for uncommon.
So the right answer is common because the pattern of the premotor ventricular beats, the right bundle branch block, superior axis, and the narrow QRS, suggesting the origin from the special eye conduction tissue. This is a second, the poll 2, is a 19-year-old soccer player. And how would you classify this particular pattern of premotor ventricular beats morphology? A, common, B, uncommon? Please vote.
Let's start voting again. Similar to before, have a look at the morphology in the precordial leads, have a look at the QRS duration, have a look at the axis, and decide whether you will classify it as a common or an uncommon pattern. I think it's normal that people give a harder look at the ECG compared to the other questions that were questions of knowledge. They try to make out whether that's a common or an uncommon pattern. We're close to 20 votes. Let's try and see if we can double that. A few seconds left. We're up to 40, which is good. Okay, so we've got about 72% saying uncommon and only 28% saying common.
So the right answer is common because the morphology is left bundle branch block with inferior axis. That means that the premotor ventricular beats originate from the right ventricular outflow tract. This is the most common morphology of idiopathic ventricular arrhythmias. So this classification of premotor ventricular beats in common and uncommon is not only an academic classification, but it's very useful for management of an athlete with premotor ventricular beats. You can see here that according to the algorithm we proposed in the paper published in the British Medical Journal, British Journal of Sport Medicine, all athletes with arrhythmias should undergo a first-line examination that include history, physical examination, resting ECG, 24-hour electrocardiogram monitoring, if possible with 12 leads configuration, maximal exercise testing, and echocardiography. This is a first-line evaluation in order to search for a possible underlying heart disease. And if the result of first-line examination are abnormal, so the athlete should undergo further additional tests in order to confirm or exclude the presence of the presumed of the suspect heart disease. Most importantly, if the results of first-line examination are normal, in other words, there are no abnormalities in the first-line examination, so the further workup depends on the pattern of premotor ventricular beats. If the pattern of premotor ventricular beats is uncommon, mostly based on the morphology, on the response to exercise, on the complexity of the arrhythmia, if uncommon, the athlete of the individual should undergo further examination, mostly cardiac magnetic resonance, in order to exclude some silent myocardial subsets such as myocardial fibrosis that are otherwise missed by the traditional routine evaluation. Most importantly, if instead the morphology and the characteristic of the premotor ventricular beats are common, there is no need for other tests because this evaluation is enough to exclude a cardiovascular disorder, and there are no sport restriction for the athlete with this kind of idiopathic ventricular arrhythmias. So poll 3 is the final poll, is a 16-year-old basketball player. How will you classify the premotor ventricular beat morphology? A, common, B, uncommon, C, other. Please vote.
So we're getting a third option here. So have a careful look at the ectopic beats and decide whether you classify them as common, uncommon, or other. So people are voting. Let's start seeing the results. You've got a few seconds left, guys. We need to do better than 10. Getting close to 20. Obviously, the third ECG was more challenging than the first and the second one. Okay, so not many votes to start with, which means it was difficult for people. About 25 voted, but the great majority say uncommon, with only 8% saying other.
Yeah. So the right answer is other. You can see here, for example, that the morphology of premotor ventricular beats is polymorphic. You can see that the first premotor ventricular beats is different for the others, but most importantly is that premotor ventricular beats are short coupled. You can see here that are very close to the normal beat. In other words, the coupling interval is very short. This kind of premotor ventricular beats are should raise alarm because they can be a beat that can induce idiopathic ventricular fibrillation. This ECG belongs to a young athlete who experienced cardiac arrest due to ventricular fibrillation in the context of a malignant early repolarization. You can see the slurring on the QRS leads T2, L2, L3, and AVF. And this is typical the association of very short coupled premotor ventricular beats and malignant early repolarization that can underlie ventricular fibrillation and sudden cardiac death in the athlete. So in conclusions, risk stratification of the athlete with the ventricular arrhythmias has evolved to the current perspective that prognosis is related to the morphology, complexity, and response to exercise rather than to the number of premature ventricular beats. Uncommon ventricular arrhythmial morphology, mostly right bundle branch block-like and superior axis, and worsening with exercise may be associated with the concealed myocardial fibrosis at risk of life-threatening arrhythmic events. Thank you for your attention.